Thank you all for coming to today's seminar. So today we have Dr. Anne Elizabeth Montgomery. Dr. Montgomery is a professor in the Department of Health Behavior. She's also the current recipient of the Quarterlet Endowed Professorship in Public Health. She's also an investigator and health science specialist in the U.S. Department of Veterans Affairs, the VA. Where I just learned that she has an office there as well. She has been working on homelessness and prevention and specifically in housing and economic security outcomes, and she'll be talking about some of the things in this population. She has co-authored over 140 manuscripts and 3 book chapters and written several reports for the VA in this topic. So what a great way to welcome Dr. Montgomery and understand this population and also, some of the epidemiological, facts within these populations. Dr. Montgomery, welcome to Episeminar.
Okay, so thanks for having me. I was asked, I guess all the presenters in this series are asked to talk a little bit about how they got here, so I'll just kind of start there. It's funny because when you're on the path, you're like, I'm all over the place. And I remember my first job after my first round of grad school being like, I'm really a stable person. I just had sort of been around a little bit. But I grew up in Mississippi, and I've kind of always been studying homelessness, but that started when I was in college. I went to college in Boston, and we had to take a year of theology and philosophy, and you could do it together, and you had to do work in the community. So I worked, I think it was like 15 hours a week for an entire school year at Pine Street Inn, which is a homeless shelter in downtown Boston. And then that kind of introduced me to sort of the issue, I guess. And then I did a full-year volunteer program after college, called Jesuit Volunteer Corps in Portland, Oregon, where I worked as a case manager in a domestic violence shelter for a year. And then I went to sort of my first round of grad school in New York City, and I got a master's in social work and a master's in public administration, and then I ended up just working for the New York City Department of Homeless Services. It just followed me around. And then I moved to Washington, D.C., and I worked for kind of a think tank that did federally funded research. And they ended up getting 2 contracts through U.S. Department of Housing and Urban Development. So we studied homelessness prevention and Housing First, which is an intervention for people with experiencing chronic homelessness and disability. So just have done all this homelessness stuff. And then I get to UAB, where I got my PhD in 2009. And I was like, I'm gonna try something different. And my dissertation was about rapid repeat adolescent pregnancy, but I had a fellowship, and then I guess the fellowship was coming to an end maybe, and I met someone in Starbucks who ran a nonprofit that did technical assistance for homelessness programs. So I was like, okay, but I still had to have my dissertation on this rapid repeat adolescent pregnancy. And then I finished my PhD. I applied for a couple of jobs kind of with the adolescent pregnancy stuff. And those didn't pan out, but the VA started the National Center on Homelessness Among Veterans the same year that I graduated, and the University of Pennsylvania was hiring a research associate for that center. So I did that instead, and I just didn't have a choice in the matter, frankly. Homelessness was going to be what I was going to do. So I have been with the VA's National Center on Homelessness Among Veterans since 2009. I was in Philadelphia for 7 years, and then I've been back here for about 10 years. So I didn't know anything about veterans before, but I've learned a lot and learned what a great place VA is to do research. And yeah, so I've been here for about 10 years. My research is all of it is through the U.S. Department of Veterans Affairs, and so I mostly do mixed methods projects where we use veterans electronic health record data, and then it's sort of kind of let's learn about whatever problem we're interested in, and then we do qualitative interviews typically with both patients and providers, because the VA is a learning health system, and so we want to learn how providers understand these problems, the interventions that they are providing to veterans, and how those can be improved or changed, or what we can learn about that. So a lot of my work is in the context of interventions. I've done a lot of work around primary homelessness prevention through developing and studying a universal screen for housing instability for all veteran outpatients. So when you go to the doctor and they're like, do you wear a seatbelt? Do you do drugs? We created a question about, are you experiencing housing instability? Now my work is, I do quite a bit around access to care in rural areas. We're doing a study to understand who calls the National Call Center for Homeless Veterans, and then how do they get connected to health services and social services. We do a lot of kind of following veterans around as they move through the health system, because the VA is a national health system with a national level health record. So the populations are kind of both providers and patients, and the outcomes, obviously, is housing stability or instability is one of the main outcomes that we're focused on, but also how and whether they're linked with a variety of care, and then also suicide, which I'll actually talk about that today, because I think it's just been kind of a long series of, we did this little study and this little study, and then we needed to know about this, so we did this other study. So we'll talk more about that. And then I do teach at the school. I teach an undergraduate service learning course and a master's course on homelessness. I know we have a former student in here. And then a core doctoral course in the Department of Health Behavior. So a lot of this y'all are going to know, but housing instability is a very important social determinant of health. I know that we're all familiar with social determinants of health, but they're the conditions in which people are born, grow, live, work, and age, and they are strong predictors of morbidity and mortality. Safe and stable housing is a key determinant of both physical and mental health. I'm a strong believer in sort of the home and housing and stability as a platform from which we are able to live our lives and do work and stay healthy and have relationships. So I'm a big believer that housing generally, or the lack thereof, is particularly important. I would probably be inconsistent with the terminology, but I try to be consistent. And I use the term housing instability because it's homelessness or housing stability. It's a state. It's not a trait. And so a lot of people say the homeless, or I like these two examples here. And housing instability really comprises a continuum from being stably housed but maybe not able to afford it next week, to, living on the streets or in shelter. And where you are in that continuum can change really at any moment. So these are two examples that I've come across. One was on people.com, Phoenix homeless man called a hero. And I was like, that's nuts. Like, they would not, if I saved somebody from a burning home, they would not say, lady who lives in a condo is a hero. It has nothing to do with anything. And so that drove me nuts. And then the next one was, I think, on a subway somewhere. And it's like, we plan to cut all homeless people in half by 2025. And I know a lot of people in here use numbers, and you just would never write the sentence that way. So what is homelessness? So it is a federally defined state. So it's living in an unsheltered situation or outside. It's living in emergency shelter, or it's living in transitional housing. So not having permanent housing. It's also
that counts your car, right?
car counts. Yep, car would be homeless. And I will say there's the definition and like the law. There's also individuals' perceptions of the stability of their housing, right? And I have a colleague who I've done a lot of studies with who's living in her van right now with her cat visiting national parks. I think if someone, she could be considered homeless. She doesn't consider herself homeless. So there's the sort of the law, and then there's personal perceptions. That's why it's really interesting. The work we're doing with the National Call Center on homeless veterans is they call and they say what their housing status is. So it's also, if you enter an institution while you're homeless and you don't have a plan to go into permanent housing after, it's fleeing life-threatening situations, again, without access to supportive housing, or also families and with children and unaccompanied youth who are likely to not have the resources to sort of kind of turn their housing status around. So based on that definition, did any of y'all participate in the point in time count of homelessness this year or ever? Awesome.
It was maybe 2017 and not.
Okay, yeah. So it was last Wednesday. So once a year across the country, we count people who are experiencing homelessness. And it happens two ways. It's not a national system, but there's 400 communities across the country that keep homeless management information systems where they can go in and say, these are the people who stayed in emergency shelter and transitional housing last night. And to identify people experiencing unsheltered homelessness. In these communities, they convene volunteers who canvass streets. And I know I was with 3 other people. We had from 6th Avenue South to 1st Avenue North, from 280 to 10th Street. And I don't know how we were supposed to do that. But they do have multiple shifts. So, but the data were collected in 2025, and the data were collected last week. They just haven't been released. So the most recent data that we have access to is from January 2024. So 2 years ago, on that one day in January, there were about 771,000 people who were identified outside or were staying in a shelter. And about a third of them were unsheltered. These numbers aren't great. I think the sheltered numbers are pretty good because it's people who've gone in and like checked into a program. They know they're there. The unsheltered, and the reason they have it in January is because more people are sheltered when it's cold, right? So, we went to go count to try to identify people who were unsheltered. It was really cold last Wednesday. And we started at 7 a.m. and you're just not going to be visible, right? And like in rural areas, you're not going to be visible. And then there's some communities like New York City where there's a right to shelter. There's some so their unsheltered numbers are low. There's some communities like Los Angeles where it's largely people who are sleeping outside. But this is kind of sort of the best job that we think we can do, and at least gives a benchmark to sort of track over time. We have seen an uptick in this number over the past couple of years. You can see they didn't do the count during COVID. And then I'm going to talk about veterans, and I didn't put this in here, but veteran homelessness, since 2009, there's just been billions of dollars put toward this issue, and the annual count, or the point in time counts, have shown about a 50% decrease in the number of veterans experiencing housing instability. There's always new people coming in, people leaving, but there's been a huge reduction. So why is homelessness a public health issue? For a lot of reasons. Risk factors, there are lots of sort of community level, interpersonal level, and interpersonal level risk factors. In the homelessness class that I teach, we talk about that. And students really sort of, you probably read Evicted when you were in the class. It was a long time ago. But we do some sort of ethnography, and students can sort of identify the risk factors at different levels. It's not just because you have a mental illness. It's not just because you're fleeing domestic violence. It is multifactorial. There's not a single community in the United States that someone can pay fair market rent if their only income is disability or Social Security. Not a single community. And one of the assignments that I do is I'm like, pick a community, look up these federal numbers about what fair market rent is, what minimum wage is, and how many hours you'd have to work a week to afford a unit, and then look on, realtor.com and find an apartment. And students every semester are like, so I can't find one. What's my answer? And I'm like, that's a pretty good answer. And that's what people are sort of up against. There's just insufficient housing in this country. So poverty, unemployment, housing market, huge community level risk factors. Having severe mental illness, substance use disorders, it's neither necessary nor sufficient to, lead to homelessness. The majority of people experiencing homelessness do not have these conditions. They likely have a higher rate of them than people who are not experiencing homelessness. But it's sort of, for some people, it's just kind of, it's part of all the factors that sort of work together to make that happen. For some, it's not. There are lots of very poor consequences of housing instability, poor health. People who experience homelessness have lack of access to health insurance, lack of access to preventive care. They often use acute care much more frequently. There's, particularly among people staying in unsheltered situations or encampments, there's often violent victimization that happens more frequently among, for example, like the trans population. And then premature mortality, for a lot of reasons, including some very specific health conditions that have a sort of a higher prevalence in this population, but also sort of someone who's experienced chronic homelessness is 20 years, their what do you say? Their like biological age is 20 years older than their chronological age, or vice versa. They just, if they're 50, they have the health of a 70-year-old. So it's a public health issue because it has very poor impacts on health. One of those is elevated rates of suicide. Not just all-cause mortality, but suicide. And there's homelessness and suicide share a lot of risk factors. And this is for the general population as well as the veteran population. And so, for example, they share all of these risk factors: chronic medical conditions, lack of social support. But they also, those who are at risk of homelessness often have, sorry, I was reading this backwards. But having prior experience of homelessness, you're at higher risk of homelessness. Same with suicide. Veterans and individuals who experience homelessness have higher rates of suicide, and vice versa. So I'm just going to talk a little bit about work I've done around housing instability and suicide among veterans. This is, for epidemiologists in the room, you're going to hate this chart because everything's from a different date and a different data source, because these numbers don't exist for everybody. For the U.S. adults and the veterans, those numbers are pretty good. I don't think in this case they're from the same year. I think the veterans is maybe 2022. U.S. adults is 2024. Death data are always lagged by 2 years, so they're going to be old anyway. Our estimates for the homeless population are they're old, and mostly based on systematic reviews and meta-analyses. So it's real messy, and it's not great, but I think the numbers are clear enough that it gives you a really good sense that rates of suicide ideation and attempt are much higher among U.S. adults who are experiencing homelessness compared to those who are not. And rates of suicide death are triple among veterans compared with U.S. adults. And again, there's quite a range, but in the literature that we have, veterans experiencing homelessness have much higher incidence of suicide death than their non-homeless counterparts. And it's a big deal. And the VA has made a big deal about suicide among veterans, obviously, and also about homelessness among veterans. There's just been so many resources to try to really get a handle on both of those issues. So this is a study from a while ago, and it was just from one area in the country. Wow, I guess the data are 10 years old. But some colleagues and I just looked at medical record data. We were able to identify from, I don't know if you're familiar, ICD codes, like diagnostic codes, and the electronic health record, different social determinants of health that a veteran may have been experiencing. And then we wanted to look to see whether they had documentation of suicidal ideation or suicide attempt in their medical record. And I'll kind of get to this later. Using medical record data, you only know you only know if someone has had suicide ideation or an attempt if they show up and tell a provider that, right? This is a super dumb example, but I remember when my mom signed up for Facebook like 15 years ago, and she's like, it says that Glenda Burke and I only share 2 friends, and we've known each other for 25 years. We have so many friends in common. And I'm like, it's only those who are in the system, you know? It's God didn't just come in and like populate it. So we're missing a lot. But we looked at all of these adverse social determinants of health, and the dark blue is evidence of suicidal ideation. The light blue is evidence of a suicide attempt. And you can see that these are adjusted odds ratios. The odds of having an indicator of housing, the odds of a suicide ideation among those, if you experience housing instability, you have triple the odds of documentation of suicidal ideation compared to those who do not. This non-specific psychosocial needs, not really a helpful category to study, but the housing instability piece had very long bars, and that's kind of what we were interested in anyway. So that was sort of an early, limited geographically and time period study where we're like, there's something here, and it's showing up in the medical record. And then other colleagues looked at, for this sample of like 153,000 veterans, they basically, the sort of black striped line in the middle is when the first sort of indicator of homelessness appeared in the medical record. And it's basically showing for a variety of healthcare services that veterans can access in the VA. So the utilization of those services increases as they become homeless, basically. And these were inpatient or ER, visit to an inpatient admission or an ER visit associated with a suicide-related diagnostic code, having a primary diagnosis of that, also documentation of an attempt or self-inflicted injury. So you can kind of see sort of like as you get closer to this indicator of homelessness in your medical record, you're starting to access really acute services. So then we were like, oh, okay, well, can the services then help with that? Can they help? Can they intervene in some way to not just prevent homelessness, but to prevent suicide? So this could have been from the same data from before. It was a long time ago. But we basically just looked at these four outcomes of suicide ideation, attempt, and death, and then all-cause mortality. And we just wanted to see if the rates were different, if a veteran accessed a VA homeless program. So these are indicators. These are veterans who, I mentioned this universal screen for housing instability. These are veterans who showed up at the VA for regular outpatient care, were asked a question about do they currently have housing, or are they concerned they're going to lose their housing. And those who didn't currently have housing, the rates of suicidal ideation were much higher among those who accessed a VA homeless program. Again, I think that's it's more easily documented when you have interaction with providers. But rates of all-cause mortality were lower for those who accessed a VA homeless program. So, our question was, okay, well, homeless programs, their primary job isn't to, well, that's not true, because everyone at the VA, your primary job is to prevent suicide, but they're here to help someone with housing. Do they need to be doing some suicide-related stuff? Because we are seeing that it may improve. People are not dying during this time period when they've accessed this homeless program, but there are higher rates of ideation and attempt. So providers are knowing this information about these veterans. So we decided to do a really big study around this, where we much more systematically identified individuals experiencing adverse social determinants of health and looked to see if services tailored specifically to that social determinant of health impacted their risk of, or was associated with their risk of suicide. So actually for this study, we looked at 3 different cohorts, and we looked for indicators in the health record that were just diagnosis codes or responses to screenings that weren't about services use, because we wanted services use to be our primary predictor. So I think that for over like a 4-year period, we identified about 663,000 veterans who had some indicator of housing instability. And then we looked to see if they did or did not receive homeless services during that time. And we did the same thing for unemployment and the same thing for justice involvement. And so among those with indicators of housing instability, about 12% had a documented experience of suicidal ideation in their record, almost 4% attempt, and 0.2% mortality, suicide mortality. Suicide's very rare. Homelessness, they're a terrible problem, but suicide's very rare. Homelessness is very rare. And we talk about these really big numbers, but we're talking, 662,000 out of 22 million veterans. That's not very rare, but anyway, we kind of get into small numbers, and this caused some problems during our later analyses when we wanted to model suicide death as an outcome. But basically what we did, it was a lot of work to get to this table that was like, no, participating in a VA homeless program, it doesn't reduce risk of suicide, or it's not associated with a reduction in risk. What we found was for suicide mortality, there were higher odds among veterans a veteran with an indicator of housing instability who went and received a VA homeless program service. They had 40% greater odds of dying by suicide. They had 10% greater odds of having a suicide attempt in their medical record. With more visits, we didn't see significance with suicide mortality as the outcome, but with suicide attempt. And we didn't think this was necessarily a bad thing because, again, we know homeless program use doesn't cause suicide. That's not what this is about. It's more, these are particularly high-need veterans who need to access these services and who are getting a variety of care. So again, we have to remember this is electronic health record. It's not populated. It's not populated by God or whoever. It's about a veteran presenting for care. And if you're presenting for homeless services, you're going to have a little more information about your other needs. And it helped us realize that, these homeless programs are a really important place where suicide prevention needs to be integrated because there's such an overlap in those risk factors, but also sort of in those needs. Other significant covariates associated with suicide mortality is a race other than Black, being non-Hispanic, lower disability compensation. So that is veterans who receive disability related to, who receive compensation related to disability incurred during military service. And the million logistic regressions that we've run since I've been at the VA, where the outcome is either homelessness or death, having higher disability compensation is always protective. One thing that really helps you not be homeless is having some money. And I know that sounds trite or whatever, but it's true. So it's not surprising that was protective, or that having a lower amount was sort of risky. Mental health outpatient care was associated with suicide mortality and suicide morbidity. So a veteran who's come in before because they had experienced suicidal ideation or they had a suicide attempt, higher odds of dying by suicide. So the next thing we wanted to do, and I won't get into it because I don't have very detailed information here, but we're like, okay, so these services aren't protective. Well, we lumped them all together. We just were like, VA, homeless services. Did you get it or not? And they're different. And the services are arranged along sort of the 3 levels of public health prevention, where we have primary services, which is asking everybody if they're having issues with their housing, or having a sort of drop-in space in the VA where a veteran can say, I need a bus token, I need a list of apartments, just available to everybody. Secondary services to prevent or rapidly end homelessness, and then tertiary, which again is like is veterans experiencing chronic homelessness. They need really a lot of services, both housing and other services. So we kind of broke it down into these 3 levels, and we're like, okay, this was sort of getting to where our hypothesis originally was that participating in homeless services would be protective. And basically what we found was that veterans who had recently left one of these programs at these different levels had increased odds of both suicide, death, and all-cause mortality. But sort of current participation in the same time frame in these programs, and each sort of type separately was protective. They had higher odds of suicide if they were exiting the program, lower if they were actively participating in it. And so exiting programs, which are sort of longer time frame and dumping them all together, sort of didn't get at that. So we needed to look at, are they in there in the same time frame? Have they left? And is it different types of services? So we basically found that exiting programs could be a very vulnerable period. And there are evidence-based practices to help with that, critical time intervention, these sort of assistance that people leaving homelessness or leaving institutional situations can sort of be reintegrated into a community. And the implications basically are that we need to address mental health and suicide prevention in the context of homeless interventions, but also when a provider is screening a veteran for suicide risk, just asking if they screen positive, are you having concerns about your housing? We know that it's so closely tied together that it's important to just sort of have that at kind of the forefront when you're screening a veteran. There's a lot of suicide screening that happens in the VA. So that's a real quick run through of that. Here are some references if you'd like to read more, and I'm happy to answer any questions if you have them.